Okay, then we request Dr. Neena Chris William, FP204, to present the paper on comparing ocular thermography at different temperatures using IDEA, Intelligent Dry Eye Analyzer.
Good morning. My paper is on comparing the ocular thermography at different temperatures using intelligent dry eye analyzer. Dry eye disease, as you know, is a multifactorial disease and it is caused by the loss of tear film homeostasis. And the most frustrating part of dry eye is the debilitating symptoms, the lack of relief from symptoms, and the difficulty in diagnosis. There are already several parameters available in the market right now to analyze dry eye, like the tear film stability test, tear breakup time. Tear film volume is measured using Schirmer's test, ocular staining, inflammatory markers, and meibography. But in spite of the existence of all these tests, we are still unable to explain why some people are symptomatic. So it probed us to search into other parameters. So as you know that the lipid layer is responsible for maintaining the evaporation of the tear film, thermography permits an indirect evaluation of the evaporation rate, and it uses a thermography camera which operates in the infrared range. And this concept was introduced in 1968 by Mapstone. However, there is no commercially available instrument. So our hypothesis was the change in environmental conditions in terms of temperature and humidity alters the ocular surface temperature and will trigger the pain receptors, causing dry eye symptoms in those who are vulnerable. The aim of our study was to compare the ocular surface thermographic changes with help of severity scores in subjects with dry eye symptoms and asymptomatic individuals at the ambient room temperature and humidity and in a temperature and humidity controlled environment using a novel device called the Intelligent Dry Eye Analyzer. So we did a cross-sectional study in a tertiary care hospital and sample size was 24. We included all those patients, those healthy volunteers in the age group of 18 to 60 years. And we excluded those people who had history of any ocular disease, were on any ocular medication or systemic medication which altered the ocular surface. And those who have undergone any ocular surgical intervention. So initially we asked the patients to complete the OSTI questionnaire on their phones using a QR code based method. And those who had scored 12 and above were classified as normal group, and those who have 12 and below were in the normal group, and those who had scored 13 and above were in the symptomatic group. An OSTI questionnaire is a valid and reliable index to assess dry eye, and it has three subscales, that is the ocular symptom subscale, the vision subscale, and the environmental trigger subscale. So we studied our patients in two settings, that is the ambient environmental temperature that is at 25 to 27 degrees with relative humidity of 70 to 75%, and the control temperature was 20 to 22 degrees with relative humidity of 55 to 60%. So this is a novel device which is based on artificial intelligence and machine learning. It has two versions. One is a standalone version on the left, and the right you can see the slit lamp clip-on version. So this machine analyzes the ocular surface thermography. It does the infrared imaging, the tear breakup time, meibography, blink rate, and finally it gives us a tear film instability. So here the patient is made to sit on the slit lamp. You can select the mode, and initially the meibography is done of the lower lid and the upper lid. Then the patient is asked to blink normally for 30 seconds, and the restricted blink mode, the ocular surface thermography is measured. Also, the tear film breakup time can be assessed. So this is a report generated. The first two images are of the meibography, and the last two are of the ocular surface thermography changes. And this machine gives a severity score, which is an analysis of the ocular surface temperature changes. As you can see, the color code, the darker color signifies warmer temperature and the lighter colors, colder temperature. So our results, our mean age group was 28 years. We had 7 males and 17 females. Out of the OSDI score, 14 people were normal and 10 were in the symptomatic group. So we compared the severity scores of those who scored normal on the OSDI score and those who were symptomatic on the OSDI score at the two temperatures, and we noticed that at the control temperature, that is at the lower temperature and humidity, they had a higher severity score compared to the ambient temperature. However, the difference between the two groups in the ambient temperature was not significant. Similarly, we subdivided the OSDS questionnaire into the ocular symptom subscale when we analyzed those who were symptomatic in the ocular symptom subscale and those who were normal on the ocular symptom subscale again had a higher severity score at the control temperature and humidity, but the difference in the ambient temperature was not very significant. Similarly, in the vision subscale 2, there's a higher rise in severity score at a controlled temperature, but at ambient temperature, the difference is not much. However, we noticed that in the environmental trigger subscale, there was a drastic and a significant increase in the severity score of those people who were symptomatic on the environmental trigger subscale. So this was a significant finding. So in our study, we showed that the ocular surface temperature variation during the interblink interval was significant in those people who are symptomatic at a lower temperature and humidity condition. Even in our study, it was just a 5-degree change, but the study was significant. We compared it with other studies. A study done by Craig et al. Showed that thermography in case of a dry eye person is more variable compared to a normal. You can see that the color code is more uniform in a normal eye compared to the dry eye patient. Similarly, a study done by Morgan et al. Showed that the surface temperature was significantly higher in a dry eye patient. It's probably because of the congestion, and that the center of the cornea in a dry eye patient became much lower than a normal eye. That's probably because of the evaporation rate is higher. And a similar study done by Kamau et al. Showed that there was a greater decrease in ocular surface temperature on sustained eye opening, which again supports that there's a higher evaporation rate happening. So we conclude that there's a poor correlation in signs and symptoms in dry eye patients using conventional techniques, which calls for a novel technology to accurately diagnose dry eye. So computerization of the clinical test has helped to increase our efficacy and reduce the time of diagnosis. And recent advances in artificial intelligence and the rapid progression in these analytical techniques have helped us overcome a lot of pitfalls in clinical testing. So ocular surface thermography using severity scores is a novel approach to understand and interpret the dry eye symptoms and reduce a mismatch between the signs and symptoms of the dry eye patients. These are my references. Thank you. Madam, this machine has not come into the market yet. We're still studying the machine, so we haven't put a price on the investigation yet. Yes, this machine is a collaboration between that and even Chaitanya also. Yes, yeah. Yes, sir. Yeah, yes.
Where do you intend to put this diagnostic test? If you see in our reduced to humidity,
Yes.
so do you find this test will place in the homeostasis marker?
Yes, sir, because the ocular surface thermography is a sign of, it gives you an idea regarding the homeostasis maintenance. So in those people who have a higher severity score, it shows that the patient is not able to maintain homeostasis. So it definitely is an important parameter to analyze.
This can be an additional.
Yes, sir.
The discussion, you referenced some articles. Did they use the same device?
No, sir. They have used another device that is using thermography camera itself, but we have used a special device with multispectral imaging using some thermal sensors, which they have not used. And this is powered with AI, artificial intelligence, and machine learning also. Yeah.
So except for, I think, the staining and the osmolarity part, everything else comes into a single unit.
Yes, sir. We have
So
other
that's
parameters.
one big advantage
Yeah.
with this device.
Staining also, we can also see the non-invasive T-bud.
Yes, it is a non-invasive T, but is also
Fine.
able to analyze.
So you will just need the osmolarity part, which has to be
Yes.
as a sort of intervention.
So how many patients you have tried this?
So, ma'am, we've done it on 24 patients. Currently, we've taken only volunteers. Yeah, so we have 24.
What's the repeatability of?
We are, you mean pre-treatment and after treatment? Yes, so currently we have analyzed them before treatment. We yet to further take the study ahead in those who
Even before treatment, what are the values that you are getting? Is it repeatable?
they are similar, ma'am.
Did you compare that?
We did it in few people. It is similar, but there's mild variation based on the temperature, because many a time when we test the patients, they are coming from a different temperature. They might be sitting in an air conditioned room or at a normal temperature. That variation is seen. So in our study, we had done a temperature control and an ambient temperature. So those are more accurate. But when you randomly measure a person, we don't know from what temperature they're coming from, a cold environment or a hot environment. So that variability is there.
So there are a lot of images to use the AI.
Yes. So we're able to easily analyze instead of if each doctor assessing, the machine itself gives us an idea, a direct result. So it saves us our time also.
What is the the number that you plan to take the
Enroll.
images? Because they to come out with some, authentic and
Yes.
dogmatic
Because
result.
what madam is saying, the test to test variability is very high.
It will be higher,
Yeah.
and you need certain number, even for artificial
standardize it.
intelligence, to come out to a conclusion that okay, this is the thing that we have to follow, because all will be following the AI. So what is the number that you want to?
So, ma'am, currently we had used only volunteers, but now we will start trying it on patients.
AI, madam, they will have the numbers already. The
You
report
will
goes
be,
to AI.
you will have
It will go to
certain
AI.
number. You
Okay.
just check on that.
Okay, sure. ma'am.
It will be in thousands. I think minimum 1,000 or 2,000.
Yeah,
They are
normal-
telling
normal
that
people
you have to normal.
Okay.
Then only you will get the
Yeah,
information there.
information.
If you don't feed, you will not get.
So how long is the, it has to connect to the internet, is it? It has to be
No, it
online.
doesn't have internet connection. Currently, the machine operates and it gives us the data immediately, the report.
For analysis.
For
sorry,
analysis.
For analysis.
Because you are telling.
Because you are using AI, how?
It's an inbuilt AI.
Yeah, it's an inbuilt AI. So we are not using internet currently. Yeah.
So inbuilt AI, so you should, like madam is asking, how much is the stock which is present, 50,000 images or 80,000 images?
You plan
Yeah.
to take.
What machine learning was used?
Yeah,
Then you
I'm yet
need
to
to analyze
understand that.
statistically. The next part is that.
Yes, ma'am.
Okay, the totally different analysis which has to be done for this. Now
Some
we are
of the,
looking at
for
the
example,
AI.
just to compare with the smart vision glasses. Smart
Yes.
vision glass is available on YouTube.
Yes.
See that. So it has to be connected to the internet constantly as the
Yes.
patient is using it.
Yes.
So as to utilize that AI services.
Yes.
In your system, you say it is
It's
already
inbuilt,
built in.
yeah.
So it's built in. So what is the stock value?
I'm
so if
don't know
it's
regarding that.
number of images are little less,
Yes.
then it has to learn more. You may have to feed it more.
Yes.
That's why companies approach us, because they need more images.
Yes.
So all companies want more images. That's why they approach us.
Okay.
Our cornea
They get
department is
images
doing
if it's
similar
free.
study,
Yeah.
not on this.
Yeah, they get free images.
They are taking pictures of keratitis.
Okay.
So keratitis, they are clinical diagnosis, and then all the images with keratitis, whether
Okay.
it's viral, fungal, or whatever, they're collecting, and the number that is fixed is 2,000.
Okay.
Arvind also.
Yeah,
Microbial
for
characteristics
example,
they're
Google
doing.
has a
this.
Prognostic.
Google has a lab in Bangalore which does for dermatology.
Okay.
For each skin lesion they have for dermatology. It's a huge center in Bangalore. So all this diabetic retina images are small values
Correct.
compared to dermatology. Okay, thank
Okay,
you.
thank you.
Thank you.